What if I told you that one of the most requested plastic surgeries in the world doesn't remove a single wrinkle? Like, it actively rebuilds the mechanics of a muscle you probably didn't even know you had.
Yeah, people are usually pretty shocked by that one.
Right. Welcome to this deep dive into the plastic surgery playbook. We have a massive stack of sources today.
We really do. We're talking highly technical surgical breakdowns from YouTube, peer-reviewed medical journals, and, insights from leading aesthetic clinic blogs.
Exactly. And our mission today is to reveal the surprisingly distinct, highly specialized worlds of Asian and Caucasian facial cosmetic surgery.
Because they are completely different worlds.
Completely. We're going to unpack the underlying anatomical differences that make these procedures so unique and explore the cultural beauty standards driving them.
Which is huge.
Yeah.
Because modern plastic surgery focuses heavily on preserving a patient's ethnic identity, not, erasing it.
Right, which I think is a big misconception. So whether you are a prospective patient navigating these choices, or maybe a medical enthusiast, or just insanely curious about how cultural history physically shapes modern medicine.
Which, it totally does.
It does. This deep dive is your ultimate guide. Okay, let's unpack this. Before we get into the biological machinery of the surgeries themselves, we really have to look at the architectural blueprints.
That's a great way to put it. You can't understand how a surgeon operates until you understand what the patient actually considers beautiful in the first place.
Right, and those foundational goals are dictated by regional and cultural standards, and they sit on almost opposite ends of the spectrum, don't they?
Oh, absolutely. If we look at the insights from the AB Plastic Surgery Clinic, Western beauty ideals heavily prioritize structure and angularity.
Like the classic Hollywood archetype.
Exactly. It's all about high projecting cheekbones, a highly defined, squared-off jawline, and that sort of sun-kissed, athletic look. The visual language there is really about projecting strength, sharp definition.
But contrast that with the Asian beauty standards highlighted across our medical sources. Historically, and still very much today, the ideal in East Asia is a slim, V-shaped face.
Yeah, a much softer aesthetic.
Right. Patients are looking for a softer jawline, a delicate, unpronounced profile, and smooth, fair skin. The visual language prioritizes elegance and a continuous, unbroken curve over that sharp, aggressive angularity.
Which brings us to a massive misconception in the aesthetic space. Board-certified plastic surgeon Dr. Shim Ching explicitly addresses this in his clinical breakdowns.
Oh, the westernization myth.
Yes. When Asian patients request procedures to, say, make their eyes larger or their noses higher,
Right.
they are not trying to westernize their appearance or look Caucasian.
Right.
That is a myth that just really needs to be retired.
It makes no architectural sense anyway. If a surgeon just copy-pastes a distinctly Caucasian feature like a specific type of deep parallel eyelid fold onto an Asian face, Dr. Ching notes that it clashes violently with the surrounding facial architecture.
It does. It never looks right. The primary goal for today's Asian patient is enhancing their natural features while strictly preserving their ethnic identity.
It's a lot like architectural renovation. You wouldn't buy a sleek, low-profile, mid-century modern home and try to hammer Victorian turrets and heavy crown molding onto it.
No, you'd completely destroy the harmony of the design.
Exactly. You want to lean into its original mid-century style so it becomes the absolute best, most refined version of itself.
And a surgeon has to respect that native blueprint. If they apply a standardized Western-centric surgical approach to a face with entirely different bone structure and soft tissue distribution.
It just looks unnatural.
Incredibly unnatural. Acknowledging the cultural and anatomical differences isn't just a matter of preference. It is the fundamental requirement for a successful cosmetic outcome.
So if the overarching goal is enhancing the natural architecture rather than fighting it, that radically changes how surgeons approach specific features.
Oh boy.
Let's take the most highly requested facial procedure in the Asian demographic, which is cosmetic eye surgery.
Yes, blepharoplasty.
Right. If you're listening to this and you happen to be near a mirror, take a look at your eyelids, because the anatomy there literally dictates the surgical playbook.
It really does. In Caucasian patients, the upper eyelid typically features a parallel fold.
Which means it goes straight across, right?
Right. It's a crease that runs entirely across the eyelid, staying parallel to the lash line. And crucially, it does not physically merge with the inner corner of the eye.
Okay, but the Asian eyelid is built differently.
Very differently. A significant portion of the population has what's called a monolid, meaning no crease at all. Or they have an inside or merging fold.
And how is that different from the parallel one?
Well, this cold is much smaller. It sits closer to the eyelashes, and the skin actually merges down into the inner corner of the eye.
So because those starting anatomies are worlds apart, the surgeries are functionally completely different procedures, even though they just happen to share the same medical name.
Exactly. Caucasian blepharoplasty is essentially an anti-aging subtractive procedure.
Taking things away.
Right. The patient comes in with excess sagging skin and bulging fat pads that make them look tired. So the surgeon's job is to just remove that excess material.
But Asian blepharoplasty is deeply structural. It's not about aging at all.
Not at all. The primary objective is to create that double eyelid fold to make the eye appear larger and longer.
And they do something with the inner corner too, right? The epicanthal fold.
Yes, surgeons frequently address that. It's a small web of skin at the inner corner of the eye, very common in Asian demographics, which visually shortens the eye horizontally.
Oh, I see.
To counter this, surgeons perform a medial epicanthoplasty. They surgically open up that inner corner, or they might do a lateral epicanthoplasty on the outer edge. Caucasian patients rarely, if ever, require these specific geometric alterations.
I have to ask about the sheer mechanics of this because I was reading the journal Insights from Dr. Chin-Ho Wang and Dr. Fu-Chan Wei, and the complexity they describe is staggering.
It really is a marvel of engineering.
If the goal is just to make the eye look bigger by adding a crease, why undergo a complex structural surgery? I mean, why not just pinch a little horizontal fold of skin, stitch it together, or just snip out a tiny strip of skin to force a crease?
What's fascinating here is the sheer brute force of the underlying machinery in the Asian eyelid. You can't just pinch and stitch the skin because the muscle underneath will actively destroy your work.
Wait, destroy it, like literally?
Literally. Dr. Wang and Dr. Wei detail how the Asian eyelid features a highly thickened orbicularis oculi muscle. That's the muscle responsible for forcefully closing your eye.
Okay.
Because it is so dense and active, it acts like a biological bulldozer against any artificial crease you try to stitch into the surface skin.
A biological bulldozer? That is a wild image.
It really is.
Yeah.
Furthermore, the levator aponeurosus, which is the main lifting tendon that opens the eyelid, fuses with the surrounding tissue much lower down in an Asian eye compared to a Caucasian eye.
Oh, so the surface skin is completely disconnected from the lifting mechanism.
Exactly.
So a superficial stitch is just fighting against a thick, powerful muscle every single time you blink. And eventually the muscle wins and the crease flattens out.
You nailed it. The failure rate of superficial techniques is exactly why modern surgeons utilize the hinge technique.
Hinge technique. Okay, how does that work?
They have to engineer a permanent mechanical connection. They go deep into the eyelid and utilize the patient's orbital septum. That's a very robust, living layer of tissue. They use it as a dynamic flap.
They use the tissue as a flap.
Yes. They surgically weave a fibrous connection from that deep lifting tendon straight through that thick orbicularis muscle directly into the underside of the dermis.
Wow. They are essentially installing a biological pulley system.
That's a great way to visualize it. When the patient opens their eye, the deep tendon engages, pulls that newly created fibrous connection, and dynamically draws the skin inward.
So it's not just a fold on the outside.
No, it creates a crisp, entirely natural-looking crease because the surgeon hasn't just folded the skin. They've fundamentally reconstructed the exact internal anatomy of someone naturally born with a double eyelid.
That is incredible. But, creating that deeper, more defined eye crease must totally change how the rest of the face is perceived visually.
Oh, it alters the entire topographic map of the face.
Right. Because if you suddenly add depth to the eye area, the bridge of the nose is going to look a lot flatter by comparison just based on the new shadows and highlights.
Exactly. And that visual shift frequently leads patients to address the nose next.
Which brings us to rhinoplasty. And if the eye surgeries were different, the nasal surgeries are literal opposites.
Complete opposites.
Dr. Shim Ching and Dr. Youngju Jang both stress this in the literature. Caucasian rhinoplasty is overwhelmingly reductive.
Right. The surgeon is taking things away. The typical Western patient presents with a dorsal bump on the bridge, a tip that projects too aggressively, or maybe an overly wide nasal structure.
So the surgical playbook there is about shaving down bone, excising cartilage, and reducing the overall footprint of the nose, like sculpting from a block of marble.
Yes, chiseling away what you don't need. But Asian rhinoplasty is almost entirely additive. It's augmentative.
So building with clay, basically. You have to add material.
Precisely. You are starting with a relatively flat bridge and a tip that lacks projection. You have to bring material in to construct a shape that doesn't currently exist.
And the anatomical hurdles there are Pretty intense, right?
Incredibly steep. Dr. Jang highlights three main issues. First, the external skin envelope is significantly thicker. Second, there is a pronounced layer of subcutaneous fat.
And the third?
The native septal cartilage, the central pillar inside the nose, is usually very small and structurally weak.
Man, it's like trying to pitch a heavy, weatherproof canvas tent, but the only support pole you have is a thin, bending piece of plastic.
That's exactly what it's like. The heavy canvas is just going to crush the pole.
Right. You cannot build a taller, more projected nose if the underlying foundation collapses under the weight of the native skin.
Exactly. So because the native cartilage can't support the new architectural goals, surgeons are forced to introduce external structural materials.
Which used to be silicone, right?
Historically, yes. The standard practice was to use silicone implants to build up the bridge. And these additive implant-based techniques actually originated in Asia decades ago.
But introducing a solid synthetic object into the nose carries massive long-term risks, doesn't it? Especially under that heavy, thick skin.
Huge risks.
The sources warned about something called contracture with those silicone implants. What is actually happening biologically when a nose contracts like that?
Well, your immune system recognizes the silicone as a foreign invader. It can't dissolve the silicone, obviously, so it does the next best thing. It walls it off.
Like builds a barrier around it?
Right. The body forms a capsule of dense scar tissue completely encasing the implant. Over the years, particularly if there is microtrauma or a low-grade infection, that scar tissue capsule begins to shrink and tighten.
Oh, wow.
As it violently contracts, it physically pulls the underlying nasal framework upward.
Yikes.
Yeah, it results in a severely shortened, structurally deformed appearance, often referred to as a pig nose. Additionally, the implant can physically shift off-center, making the bridge look crooked.
That sounds awful. To avoid your body basically crushing its own nose, the shift has been toward autologous tissue, right? Using materials harvested from the patient's own body.
Yes, that's becoming the gold standard.
The sources specifically highlighted glued and diced costal cartilage, which is rib cartilage. But I have to ask, why dice it?
It seems counterintuitive, doesn't it?
Totally. If you need a strong, solid bridge to hold up that heavy skin, wouldn't a solid carved piece of your own rib bone be the strongest option? Why turn it into cartilage soup?
This raises a really important concept called tissue memory. Solid rib cartilage is incredibly strong, but it has a natural curve to it. I mean, it's designed to wrap around your chest cavity.
Right, of course.
Even if a surgeon carves a perfectly straight block of rib cartilage for your nose over months or years, that cartilage remembers its original shape.
Wait, it actually warps back.
It does. It can warp and bend, leaving you with a curved nasal bridge.
That is wild.
So by dicing the cartilage into tiny 1-millimeter cubes, you completely destroy the tissue structural memory.
You break the tension.
Right. You destroy the tension. Surgeons take those tiny diced cubes, mix them with a specialized biological glue derived from human blood products, and pack that mixture into a custom mold.
Oh, so they make a brand new shape.
Exactly. It creates a smooth, perfectly shaped, rock-solid bridge that will absolutely never warp. And because it's the patient's own organic tissue, the immune system ignores it.
That is genius. The risk of rejection or severe contracture drops to near zero.
It's zero, yeah.
Okay, so we've rebuilt the eyes using dynamic hinges. We've constructed a new nose using diced rib cartilage. But what about the terrain all of this sits on? Let's talk about the canvas itself, the facial bones and the skin. Here's where it gets really interesting.
It definitely does.
If Westerners want a sharp, angular jaw and high cheekbones, they often get implants or structural fillers.
Which is additive.
Right. But since Asian patients generally have wider cheekbones and a more prominent squared jawline natively, and their cultural goal is a soft, oval V shape, their bone contouring has to be reductive.
Right, subtracting bone.
But how do you actually shrink a cheekbone? Like, if you literally break the bone and push it inward, where does all the surrounding muscle and tissue go? Doesn't the face just instantly sag?
That is the million-dollar question.
Yeah.
The mechanics of facial bone contouring, specifically zygoma reduction, which is reducing the cheekbone, are highly delicate.
I would imagine.
Surgeons don't just shave the surface down, they perform an osteotomy.
Yeah.
They strategically cut the bone at two ends, physically slide the central segment of the cheekbone inward to narrow the face, and then secure it in its new position with tiny titanium plates.
So they literally move a whole section of bone.
Yes. And to answer your question about sagging managing the soft tissue, is the hardest part.
Because it suddenly got slack in it.
Exactly. If a surgeon strips too much muscle or ligament away from the bone during the procedure, the tissue will inevitably droop, causing premature aging. The modern playbook requires preserving as many of those native ligament attachments as possible.
So that when the bone moves inward, the soft tissue tightly follows it.
You got it. It goes right along with the bone.
Wow. Okay, so the bone work is the deep foundation, but the skin layered on top of it has its own completely distinct properties.
It absolutely does.
The AB Plastic Surgery Clinic notes that Asian skin is significantly thicker, primarily due to a denser layer of dermal collagen.
Which is fantastic for aging.
Right. If you're looking at superficial aging, that is a superpower. Thicker skin strongly resists the mechanical folding that causes fine lines and wrinkles.
Yeah, you just don't see the creepy, highly wrinkled skin as early as you do in thinner Caucasian skin. It is a profound biological advantage against superficial aging.
But, gravity doesn't care about collagen.
Nope, gravity always wins.
Eventually, as these patients age, it's not the wrinkles that drive them to the surgeon. It is the sheer weight of the face.
Exactly.
That thick skin, combined with heavier facial fat pads, begins to descend. It takes that highly desired, delicate V-shaped jawline and pulls it down, making the lower face look heavy, rectangular, and kind of boxy.
Which goes completely against the beauty standard we talked about earlier.
Right. So if a surgeon is trying to perform a facelift on an Asian patient, how do they mechanically fight the weight of that heavy skin without just stretching the patient's face into a wind tunnel look?
Well, if a surgeon relies on older, skin-only facelift techniques, literally pulling the skin backward toward the ears and stitching it tight, it will categorically fail on an Asian patient.
Because the skin is too heavy.
Way too heavy. Within a few months, the weight of the face will stretch the skin right back out. And worse, that extreme tension will cause the surgical scars around the ears to visibly widen and thicken.
Oh, that sounds terrible.
It is. Modern aesthetic surgery solves this with a deep plane facelift.
So they bypass the skin entirely?
Entirely. Beneath the skin and fat is a fibrous layer of connective tissue and muscle called the SMAS, the superficial musculo-aponeurotic system.
The SMAS.
Think of it like a dense fiber shirt you wear under your skin.
Yeah.
The surgeon goes under that SMAS layer, releases the restraining ligaments, and physically lifts that entire deep structural shirt back up to its youthful position.
Like hoisting the sail.
Exactly. They anchor that heavy load-bearing tissue securely to the dense fascia near the temples and ears. Once the deep architecture is bearing 100% of the weight, the surgeon just gently redrapes the surface skin over the new foundation with zero tension.
Zero tension, meaning no stretched look.
No stretched look, and beautifully thin, invisible scars.
And that attention to scarring is paramount, because Dr. Ellis Choi brings up a critical biological reality in our sources, which is scar aversion.
Yes, this is a huge factor.
Asian patients, and really anyone with more highly pigmented skin, are statistically at a much higher risk for excessive scarring.
They are.
But why? Why does having more pigment suddenly change how your body heals a cut?
It comes down to the behavior of fibroblasts. Those are the cells responsible for producing collagen to heal a wound.
Okay, our collagen superpower cells again.
Right. But in skin with higher melanin content, for reasons that are still being heavily researched, these fibroblasts tend to be hyperactive during the inflammatory phase of wound healing.
So they just do too much.
Exactly. Instead of just producing enough collagen to bridge the gap of a surgical incision, they go into overdrive. They overproduce collagen, creating raised, thick, discolored scars known as hypertrophic scars.
Or keloids, right?
Yes, or in severe cases, keloids, where the scar tissue grows wildly beyond the original boundaries of the wound.
That makes total sense. If your body is hardwired to potentially overreact to any incision, you're going to avoid anything that requires a large surgical opening.
Absolutely.
Which perfectly explains the massive rise in fat grafting mentioned in the sources. Like if an Asian patient wants to add volume to their cheeks or even undergo breast augmentation, they are incredibly hesitant to use synthetic implants.
Right, because implants require larger incisions, meaning a higher risk of keloid scarring, plus the risk of foreign body reactions we talked about earlier with the nose.
So fat grafting brilliantly bypasses both of those risks.
It really does. A surgeon can harvest excess fat from the patient's abdomen or thighs using specialized microcannulas.
And those are tiny, right?
So thin, they only require a puncture wound the size of a freckle, which heals virtually invisibly. The fat is purified to isolate the healthiest, most robust cells, and then strategically injected into the face or breast to add natural soft volume.
It's using your own biology as the ultimate filler.
Exactly. No synthetic materials, no large incisions, and you get the exact subtle, natural-looking enhancement that aligns with the cultural beauty standard.
It really is a masterclass in adapting medical techniques to biological realities. We have covered an immense amount of ground today.
We really have.
From the cultural blueprints to the muscular bulldozers and the eyelids to dice rib cartilage and deep fascia lifting. So looking at the playbook for the patient, what does this actually mean if you are navigating the space right now?
If we connect this to the bigger picture, the overarching directive from experts like Dr. Shim Ching and Dr. Ellis Choi is that choosing a highly experienced, board-certified plastic surgeon is non-negotiable.
Right, but we have to redefine what experience actually means in this context, don't we?
We do. It is not just about the raw number of hours they've spent in an operating room.
Right. If you are an Asian patient, your surgeon needs a profoundly specific technical vocabulary. They need to understand the exact fusion point of your levator aponeurosis.
Exactly.
Yeah.
They need to anticipate the mechanical weakness of your septal cartilage, and they must know exactly how to manage the intense weight and hyperactive healing response of your specific skin type.
Furthermore, they must possess absolute cultural fluency. I mean, a surgeon can be technically flawless, but if they lack the cultural context, if they attempt to impose a Western aesthetic paradigm of sharp angles onto an Asian facial structure.
The result will be visually jarring. It just won't work.
Exactly. The surgeon's true expertise lies in balancing your personal cosmetic aspirations with a deep respect for and preservation of your ethnic identity.
It demands a completely bespoke, highly customized approach to human anatomy.
Doing your homework is the ultimate playbook move. It's not about finding someone who is simply good with a scalpel. It is about finding the right architectural partner for your specific biological makeup and cultural background.
Couldn't have said it better myself.
So, what does this all mean? We've seen how taking a standardized, one-size-fits-all approach to cosmetic surgery just doesn't work.
Nope.
Today, we traveled from the contrasting cultural beauty standards, the Western desire for aggressive angularity versus the Eastern pursuit of the delicate V-shape.
We covered a lot.
We really did. We dug into the incredible structural mechanics of eyelid hinges, the brilliant engineering of diced cartilage nose bridges to defeat tissue memory, and the scar-minimizing wonders of deep plane lifts and autologous fat grafting.
It's a testament to how far medical science has evolved to respect, rather than overwrite, our natural diversity.
It really is. But I want to leave you with a final thought to mull over. We live in an increasingly borderless, interconnected world.
Very true.
Western audiences are consuming vast amounts of Eastern media, like K-pop, K-dramas, and aesthetics are exploding globally. Simultaneously, Eastern audiences remain deeply engaged with Hollywood and Western pop culture.
So true. Everything is mixing.
Exactly. So as our digital and media landscapes become entirely globalized, will we eventually see these distinct regional beauty standards bleed together into one universal, homogenized global aesthetic? Or will the deep-seated human desire to preserve our unique cultural and ethnic identities push medicine in the opposite direction, leading to even more hyper-specialized, culturally distinct surgical techniques in the future?
That is a really profound question.
It's a fascinating question about where culture, identity, and the literal shape of medicine will take us next. Thank you for joining us on this deep dive into the plastic surgery playbook. Keep questioning, keep learning, and take a moment to appreciate the incredibly complex biological machinery behind the faces we see every day.